Hi everyone, welcome back to the channel. In this video, we are going to see the latest medicine updates of the year 2023. This latest update in medicine, which could be very helpful for those who are giving NEET and INISS exam. This video could be long as there are almost more than 50 new updates, but we'll try to learn them as a bullet points instead of full explanatory videos. And also, you can join my WhatsApp channel. I will provide the link in the description where I will be sharing the PDF of this presentation, and I have highlighted the important points, and also I have marked the points which could be asked as a MCQ in the upcoming exams. So make sure you check that out. So now let us begin with the video. The first update comes from the topic dementia. There is a new drug known as aducanumab. It is a monoclonal antibody that targets amyloid protein. It basically promotes the clearance of this amyloid beta protein from the brain, and it has become the first new drug to be approved by FDA for the treatment of Alzheimer's disease since 2003. The next update is from optic neuritis. Basically, till now we used to use 1 gram of methylprednisolone for 3 days for the treatment of optic neuritis. There are new upcoming therapies which include monoclonal antibodies against immune cell and cell-based therapies to deplete the or modulate the T and B cell responses. The next update is from bacterial rhinosinusitis. Basically, dupilumab is a new drug which is a monoclonal antibody which inhibits interleukin 4 and interleukin 13. It is FDA approved for the patient with chronic sinusitis with nasal polyposis. Next update is from sensory neural hearing loss. Basically, there are new emerging evidence coming that the conventional audiometry may not fully capture the hearing loss, and hence few patients may have subclinical hearing loss, and this is known as hidden hearing loss. A very important update has come on cirrhosis. In the patients with clinically significant portal hypertension, carvedilol, which is a non-selective beta receptor antagonist with an alpha 1 blocking activity, appears to reduce the frequency of decompensating event, and although it may lead to hypotension, particularly in patients with decompensated cirrhosis. So this is a very important update. Next update is vancomycin should be added in a patient who has prior bacterial peritonitis or a patient who has a positive surveillance swab for methicillin resistant Staph aureus. Daptomycin should be added in a patient with a positive surveillance swab for vancomycin resistant enterococcus. Meropenem can be used in patient with current or recent exposure to pipzo, that is piperacillin with tazobactam. Update on hemochromatosis. Serum biomarkers of fibrosis may be an alternative to liver biopsy for identifying the advanced fibrosis. So in patient of hemochromatosis, we can use serum biomarkers instead of liver biopsy to diagnose advanced fibrosis. Update on non-alcoholic fatty liver disease. Non-invasive approaches for the assessment of fibrosis is now preferred instead of liver biopsy, and the liver biopsy is reserved for those in which non-invasive testing are inconclusive. For this non-invasive testing, we use FIB4 score, that is also known as FIB4 score, which includes age, platelet count, serum AST and ALT levels. In primary biliary cholangitis, obeticholic acid, a farnesenoid X receptor agonist, can cause serious liver injury in patient with advanced cirrhosis, and its use in patient have been restricted by FDA. So it is a negative update that we cannot or we should not use this obeticholic acid, a farnesenoid X receptor agonist, in such patients. Two updates on acute diarrhea. Basically, immune checkpoint inhibitor therapy for malignancy may cause mild to severe GI side effect. In patient with severe diarrhea or dysentery and unknown history of IBD or prior immune checkpoint inhibitor therapy, such patients require expedited evaluation with stool studies and possible sigmoidoscopy or colonoscopy with biopsy to exclude infection prior to the therapy with intravenous corticosteroids. So before starting IV corticosteroid, in this patient, we should always do either stool studies or sigmoidoscopy and colonoscopy with biopsy to exclude any infection. Another update is those children who have been infected with E. coli, which produces Shiga toxin. In such patient, antibiotics should not be given as it may increase the risk of hemolytic uremic syndrome. Next update is on anorectal infection. Basically, nucleic acid amplification testing for gonorrhea and chlamydia has an excellent sensitivity and specificity and is preferred for most of the clinical settings. Update on chronic diarrhea. Elevated fasting levels of bile acid precursor, that is 7-alpha C4. It is a strong predictive of bile acid diarrhea. The cutoff value is more than 48 ng per ml. Another update is on gastrointestinal hemorrhage. Basically, in those patients who have active bleed and massive bleed, in such patient we cannot use thermocoagulation or endoclip placement during the surgery. So for such patient, a new powder has come, that is endoscopic application of topical hemostatic powder known as hemospray may provide a temporary hemostasis for up to 24 hours in patient with massive bleeding that interferes with effective application of thermocoagulation or endoclip placement. Next update is on IBD. A new drug known as ozanimod is approved by FDA for treatment of moderate to severe ulcerative colitis. Two new updates on IBS. One is peppermint oil may be useful to relieve the global IBS symptoms and abdominal pain, and another is use of probiotic are not recommended for treatment of IBS. Next update is on primary esophageal motility disorder. Opioids may exacerbate esophageal dysmotility and should be discontinued if possible. No medication have shown to improve the symptoms in patients with esophageal hypomotility. Another update is on peptic ulcer disease. Commercial laboratory have now offer culture-based and molecular-based susceptibility testing for H. pylori, which may be helpful for the patient who failed an initial empirical course of treatment. Next update is on Zenkus diverticulum. Minimally invasive intraluminal approaches that use flexible endoscope or rigid esophagoscope are preferred when symptomatic patients require a cricopharyngeal myotomy. Another update is on preterm labor. The recommended regimen for antimicrobial prophylaxis against group B beta streptococcus is penicillin G 5 million unit intravenous as a loading dose, and then 2.5 to 3 million unit intravenous every 4 hours until delivery. The next update is on complex regional pain syndrome, which usually develops post surgery. In such patient, vitamin C supplementation has shown to be protective. Next update is on gonococcal arthritis. The treatment of disseminated gonorrhea is parenteral ceftriaxone. Once susceptibility testing has been obtained, for 24 to 48 hours after clinical improvement, the antibiotic regimen can be changed to oral agent to complete the 7-day course. The next update is on GPA, that is granulomatosis with polyangiitis. The American College of Rheumatology favors rituximab as a first-line induction therapy. Cyclophosphamide may also be used for induction therapy. A new drug known as avacopan is FDA approved as an add-on therapy for severe ANCM, that is ANCA-associated vasculitis, induction therapy in combination with the rituximab or cyclophosphamide plus corticosteroid. For non-severe disease without life-threatening or organ-threatening manifestation, methotrexate up to 25 mg oral or subcutaneous weekly plus corticosteroid may be effective induction therapy. The rituximab dosed at fixed interval of 1 gram every 6 months or 500 mg every 4 months is favored as a first line for maintenance treatment. Another update is on polyarteritis nodosa. A high dose of pulse methylprednisolone is recommended as the initial treatment for severe PAN. Next update is on relapsing polychondritis, and I think it is the most important update. A newly described genetic syndrome known as VEXAS, that is vacuoles E1 enzyme X-linked autoinflammatory somatic. It is a weird name, but it is a new genetic syndrome, and it is caused by somatic mutation in UBA1 in a hemopoietic progenital cell. Clinical feature includes hematological manifestation like cytopenias, bone marrow failure, and a spectrum of inflammatory features such as chondritis, vasculitis, fever, and arthritis. So basically, it includes some features of autoimmune vasculitis and some features of hematological disease. This is a rare syndrome, predominantly in males because it is X-linked, obviously, and should be considered in the differential diagnosis of chondritis, especially in presence of unexplained macrocytosis and evidence of systemic inflammation, that is high CRP and ESR. Next update is on rheumatoid arthritis. So basically, rituximab in the patient of rheumatoid arthritis should be used with caution if the patient is having COVID-19 infection. Because rituximab reduces the humoral immune response, it should be used with caution during the COVID-19 pandemic, as multiple studies have suggested that a higher risk of mortality from COVID-19 in the patient using this medication. Another update is on systemic lupus erythematosus. Belimumab is FDA approved for the treatment of active lupus nephritis. Next drug is anifrolumab, which is a type 1 interferon receptor antagonist, and it is FDA approved to treat the non-renal lupus that has not responded with the standard therapies. Another drug is voclosporin. It is a novel calcineurin inhibitor. It is FDA approved to treat the active lupus nephritis when used in combination with the mycophenolate mofetil. Another update is on systemic sclerosis, that is known as scleroderma. Tocilizumab, that is interleukin 6 inhibitor, slows the rate of decline in the pulmonary function and may use as an alternative for the patient who cannot tolerate mycophenolate mofetil. Azathioprine is an additional option for treatment of systemic sclerosis associated with lung disease. Another update on hyperkalemia. Small studies have suggested that the utility of patiromer and sodium zirconium cyclosilicate in acute hyperkalemia if administered for hyperkalemic emergency. Sodium zirconium cyclosilicate is preferred due to its more rapid onset of action. So basically there are two drugs, patiromer and sodium zirconium. Out of which sodium zirconium is better as it has more rapid action. Another update on diabetic nephropathy. Mineralocorticoid receptor antagonism can be considered for blood pressure and proteinuria management in type 2 diabetes patient with careful monitoring of hyperkalemia. Next update is on IgA nephropathy. Basically, SGLT2 inhibitors may be added to the standard care in well-selected patients. There are conflicting data regarding the efficacy of corticosteroid for reducing the proteinuria and slowing the progression. However, they may be considered for the patient with GFR greater than 30 ml per minute and persistent proteinuria greater than 1 gram per day, despite maximum ACA or ARBs. Next update is on idiopathic intracranial hypertension. We have already discussed the update on dementia. In idiopathic intracranial hypertension, which is also known as pseudo tumor cerebri, weight loss is important. Bariatric surgery led to a decrease in both intracranial pressure and weight at 2 years compared with the community weight management program in randomized control trial, and may considered in a patient with BMI of 35 or greater. So for weight loss, there are many programs, but bariatric surgery have outstanded all of them. Metastatic intracranial tumor. Memantine 5 mg once daily orally titrated by 5 mg weekly to 10 mg twice daily reduce the cognitive toxicity associated with whole brain radiotherapy in a randomized control trial, and is recommended. This effect can be augmented through intensity modulated radiation therapy with hippocampal avoidance. Next update is on muscular dystrophies. The casimersen is FDA approved for the treatment of Duchenne muscular dystrophy. It shows benefit in the patient with mutation amenable to exon 45 skipping. Another update is on TIA, that is transient ischemic attack. Dual antiplatelet therapy with aspirin and clopidogrel is recommended for 90 days after a TIA or stroke due to 70 to 99% stenosis of the intracranial artery. The left atrial appendages is the source of embolism in most patients with AF. Several randomized trials have shown percutaneous left atrial appendage closure was equivalent to anticoagulation in preventing stroke and systemic embolization, and several devices are approved for this indication in United States and Europe. The procedure should be considered in patient with contraindication to long-term anticoagulation, although short-term anticoagulation of 45 days followed by dual antiplatelet therapy for 4.5 months and then indefinite aspirin monotherapy is usually necessary after device replacement. Next update is on psychosexual disorder. A new drug has been approved by the FDA known as bremelanotide. It is for use for hypoactive sexual desire disorder in premenopausal women. However, mechanism of action is unclear and subjective improvement is low. Another update is on somatic symptom disorders. Physical based therapies such as speech, occupational or physical have strong evidence for improving symptoms in those suffering from functional neurological disorders. Next update is on trauma and stressor related disorders. Drug known as MDMA, that is methylene deoxymethamphetamine, also known as ecstasy, significantly enhanced the treatment effect associated with manualized therapy for severe PTSD. Another update is on treatment of high LDL cholesterol. The FDA has approved a novel PCSK9 inhibitor known as inclisiran, which uses silencing of RNA technology to reduce liver production of PCSK9 protein by approximately 80%. Twice yearly dosing is novel for lipid lowering therapy. Inclisiran enables new delivery strategies including in-clinic administration. Another very famous update on obesity, that the semaglutide, that is GLP-1 receptor agonist, is FDA approved for the treatment of obesity. Infections in immunocompromised patients. While traditional approach was to continue antibiotic until resolution of neutropenia, current evidence support that early discontinuation of antibiotic in neutropenic patient who become afebrile for 72 hours if no signs or symptoms of infection persist. So earlier we used to continue antibiotic until resolution, but now we have to stop the antibiotic in neutropenic patient once the patient is febrile for 72 hours and there is no signs and symptoms of infection. Next update is on HIV and AIDS. In the ANCHOR study, which involved nearly 4,500 individuals with anal high-grade squamous intraepithelial lesion, 9 patients who were assigned to aggressive therapy, most office-based electrocautery, developed anal cancer compared with 21 patients of those in active monitoring group, representing a 57% decrease in the relative risk over the median 25.8-month follow-up period. This pivotal study will change the care towards more aggressive screening of this high-grade intraepithelial lesion and treatment to prevent the progression of anal cancer. Another update is for healthcare workers, that is a drug known as cabotegravir has been approved by FDA as a pre-exposure prophylaxis as an injectable medication every 8 weeks. This medication has shown to be superior to the oral tenofovir disoproxil fumarate or amtricitabine in preventing HIV infection among men who have sex with men, transgender women and who have sex with men, and cisgender women in sub-Saharan African. Another update is on prophylaxis of Mycobacterium avium complex, as prophylaxis against this MAC is no longer recommended in most individuals who are initiating ART, including those with CD4 count of less than 50 cells per MCL. The incidence of Mycobacterium avium complex infection is very low among those on ART. A trial known as Temprano trial showed that individual immediately initiated ART versus delaying the treatment for CD4 count to fall below 500 had lowers the rate of severe illness. So as we are all aware that in HIV patient now we have to treat each and every patient irrespective of CD4 count. Now a few more updates on infectious disease like Ebola virus disease. The WHO had recommended automated or semi-automated nucleic acid test for EDTA anticoagulated whole blood for symptomatic patient for routine diagnostic management and rapid antigen detection test in areas where NATs are not available. Oral fluids can be used for diagnostic when blood collection is not possible. Update on poliomyelitis. A novel oral polio vaccine type 2 has been developed in response to ongoing circulating vaccine derived type 2 poliovirus outbreak and has shown to be safe and immunogenic in previously immunized adult. Studies have shown that this novel oral polio vaccine type 2 is more genetically stable than the old polio vaccine and therefore less prone to reverting to the neurovirulence. This new vaccine was recommended for initial use under WHO emergency use listing procedure in November 2020. The next update is on tick-borne encephalitis. Ticovac, also known as FSME Immune in Europe, was FDA approved. This is a vaccine against this tick-borne encephalitis. This vaccine is indicated for those residing or traveling to endemic areas. Next update is on African trypanosomiasis, that is sleeping sickness. A new drug known as fexinidazole is recommended by WHO as a first-line therapy and is FDA approved for the treatment of early and advanced CNS West African disease. Another update is on leishmaniasis. Alternate therapy has been approved for treatment of cutaneous leishmaniasis. This drug is known as miltefosine, which has benefit from oral dosing and is relatively little toxic, and amphotericin B, which is widely available. Update on malaria. Artemisinin resistance is mediated by any of the series of mutations in the Plasmodium falciparum KELS, that is K13 gene, of greater concern. These same mutations and evidence for delayed clearance after treatment with the artemisinin were reported in East Africa in 2021. Next update is on candidiasis. A new drug known as ibrexafungerp. It is a highly bioavailable glucan synthase inhibitor, may be used to treat vulvovaginal candidiasis from any disease causing candida strain, including azole-resistant pathogens. Next update is about marijuana and synthetic cannabinoids. Cannabidiol, a constituent of cannabis that does not produce THC like intoxication. These cannabidiol extracts are available over the counter and via the internet for variety of proposed effects: anti-inflammatory, antioxidant, and anxiolytic. And by prescription for some pediatric seizure disorder, overdoses are typically not dangerous. Another update on theophylline and caffeine. Hemodialysis has been used in patients with caffeine overdose, and ECMO, that is extracorporeal membrane oxygenation, has been used successfully in hemodynamically collapsed patient after caffeine overdose. Next update is on bladder cancer. A new drug known as pembrolizumab has been FDA approved for the patient with high risk non-muscle invasive bladder cancer who have failed with the intravesical BCG therapy. The next update is on dyspnea. Basically, the point of care sonography, that is POCUS, has consistently improved the sensitivities of standard diagnostic pathway to detect heart failure, pneumonia, pleural effusion, pulmonary embolism, and pneumothorax. And this has led to mortality benefits and decreasing the length of hospital stay. However, did not differ significantly between patients who did not receive the POCUS in addition to the standard diagnostic test. So it is also an update. The next update is on dysuria. Basically, a systematic review and meta-analysis have found that D- is protective against recurrent UTIs. Another update is on fatigue and systemic intolerance disease, that is chronic fatigue syndrome, which is also known as myalgic encephalomyelitis. Basically, a new drug has came which is known as pitolisant. It is a selective histamine H3 receptor antagonist which has wake promoting effect and may reduce the daytime sleepiness in the patient with moderate to severe obstructive sleep apnea who do not want to continue the positive airway pressure treatment. The next update is on ABPA, which is allergic bronchopulmonary aspergillosis. Basically, now biological agents can also be used in a patient who has frequent exacerbations. Drugs like omalizumab, which is anti-IgE, like mepolizumab, which is anti-interleukin 5, and dupilumab, which is anti-interleukin 4 receptor, has shown to improve the outcomes. Another update is on bronchial carcinoid tumors. Basically, aggressiveness of the bronchial carcinoid tumors is determined by cell histology, with typical carcinoid as a low-grade tumor and a typical carcinoid as an intermediate grade tumor. There is a new update on screening of the lung cancer. This update is given by US PSTF. Its full form is United States Preventive Services Task Force. This task force has updated and recommendation for low-dose CT screening. Basically, those who are at high risk of lung cancer, for example, age group between 50 to 80 years, or those who have at least 20 pack years of smoking and either current smoking or have left smoking or stopped smoking within last 15 years. The screening has to be stopped once 15 years have been crossed and the patient hasn't smoked. The next update is on chronic stable angina pectoris, which is also known as chronic coronary syndromes. Basically, CT functional fractional reserve, which is also known as CT-FFR, has been approved for clinical use. It has been endorsed with a level 2A recommendation for intermediate risk patient with no chest pain and no prior history of CAD, with a 40 to 90% stenosis on CT imaging to guide the need of revascularization. So basically, in high risk patient, we can use CT functional fractional reserve as an investigation to guide revascularization. Next update is on heart failure, but I'm sure all of you have been familiar with these drugs. FDA has approved sacubitril with valsartan in the patient with heart failure and preserved LV ejection fraction, particularly patient with ejection fraction less than 50%, including patient with mildly reduced ejection fraction, that is 41 to 49%. Another update is empagliflozin has been approved to treat the heart failure with reduced LV ejection fraction with or without diabetes. We are well aware that it is SGLT2 inhibitor. Next update is on infectious myocarditis. Basically, in the patient who had COVID-19 infection or who have received vaccine for the same, myocarditis has been reported and in the medical literature. Hence, COVID-19 leads to myocarditis, or even vaccination can lead to myocarditis. Next update is on primary and secondary prevention of CHD. This update is also given by USPFTF. This says basically those patients who are in between 40 to 49 years of age, a conversation should be held between doctor and the patient regarding the benefit and potential risk of use of aspirin in them, and the aspirin should be used as a primary prevention of cardiovascular event. And also, patient with age 60 years or older should not initiate aspirin for primary prevention of CVD. Another update is on aortic dissection for the patient who cannot tolerate beta blocker. Now, to control the hypertension, intravenous calcium channel blockers, for example, nicardipine, can be used as an alternative. The dose of the nicardipine is 5 mg per hour intravenous. Next update is on occlusive disease of femoral and popliteal arteries. Basically, dual treatment with rivaroxaban 2.5 mg orally twice daily and aspirin 81 mg orally daily has shown to reduce the limb related events, for example, major amputation and cardiovascular event in patient with femoral and popliteal artery atherosclerosis. Another update is on plasma cell myeloma. For the patient with multi-agent refractory disease, chimeric antigen receptor T cell therapy targeting early plasma cell antigen BCMA. BCMA is basically B cell maturation antigen, has shown response rate exceeding 70% and median duration of response is over 11 months. Another update is on antithrombotic therapy. For the patient with morbid obesity, standard dose of ipixaban or rivaroxaban should be chosen rather than using dabigatran or endoxaban. Direct oral anticoagulants are not recommended for venous thromboembolism treatment in the acute setting following bariatric surgery, but can be considered for ongoing treatment after initial 4 weeks of therapy. Heparins may be preferable for initial therapy in hospitalized patient with clinical instability and fluctuating renal and hepatic function, when bleeding risk is high or when there is concern that thrombolysis may be required. So in such patient we have to use heparin. Primary venous thromboembolism prevention and treatment in severe COVID-19. Therapeutic dosing of anticoagulation may benefit some patients who are hospitalized in acute care setting with COVID-19 who have very elevated D-dimer values and require supplemental oxygen and who have low bleeding risk. There is no clear benefit from venous thromboembolism prophylaxis for the patient with COVID-19 who do not require hospitalization. Few updates on carcinoma of the breast. Few drugs have been approved for breast cancer and have shown good result, like olaparib. It has shown to reduce the relative risk of invasive recurrence for BRCA1 or 2 carrier with high recurrence disease. Another drug is abemaciclib, which has shown to improve the invasive disease-free survival for those with high risk of HR positive disease. Next drug is pembrolizumab. It has shown to improve the event-free survival for the patient with stage 2 or greater triple negative breast cancer. Some more drugs have been approved for breast cancer. The hormonally driven breast cancer may particularly sensitive to inhibition of cell cycle regulatory protein called as cyclin dependent kinase 4 and 6. 3 oral drugs for cyclic dependent kinase 4 or 6 inhibitor known as palbociclib, ribociclib and abemaciclib are approved by FDA for treatment of HR positive HER2 negative metastatic bone cancer. Few updates related to OBS-GYN intrauterine devices. The levonorgestrel 52 mg intrauterine device can be inserted within 5 days following single episode of unprotected mid-cycle coitus as a post-coital contraceptive. Update on PID, that is pelvic inflammatory disease, salpingitis or endometritis. The recommended outpatient regimen is ceftriaxone 500 mg intramuscularly 1 gram for person who weighs 150 kg or greater, plus doxycycline 100 mg orally twice a day for 14 days, with metronidazole 500 mg orally twice a day, or a single dose of cefoxitin 2 gram intramuscularly with probenecid 1 gram orally plus doxycycline 100 mg orally twice daily for 14 days, and metronidazole 500 mg orally daily for 14 days. So basically 2 regimens are there, which include 1 intramuscular injection and 2 oral drugs. Next update is on cholelithiasis and cholecystitis. The most common cause of pancreatitis in pregnancy is gallstone. The diagnosis can be confirmed with appropriate history and elevated serum amylase or lipase. Management is conservative, including bowel rest, intravenous fluids, and supplemental nutrition if necessary, and analgesics. CT imaging should be avoided unless severe complications are suspected. So we usually avoid CT imaging in pregnant lady, but even in such situation like cholelithiasis, we should avoid CT unless severe complications are suspected. Immunization during pregnancy. Vaccination against COVID-19 is recommended for women who are pregnant, trying to get pregnant or may become pregnant, and those who are breastfeeding. The CDC has determined that the benefits of vaccination outweigh any risk. There is no such evidence that the vaccination can cause problem with fertility in men or women. Pregnant women who have vaccinated may receive COVID-19 booster shot. There have been rare reports of thrombosis with thrombocytopenia syndrome in women younger than 50 years of age who receive Johnson & Johnson's Janssen vaccine. This risk has not been found with other vaccines like Pfizer, BioNTech and Moderna vaccine. Next update is on maternal hepatitis B and C carrier state. Universal screening for hepatitis C virus in pregnancy is recommended. Direct acting antiviral regimen should only be initiated during pregnancy if in the setting of clinical trial. Caesarean section is not recommended solely for the maternal history of hepatitis C. During labor, early rupture of membranes and placement of fetal scalp electrode should be avoided if safe to do so. Another update is on bronchogenic carcinoma. The FDA has approved sotorasib for treatment of KRAS G12C mutated lung cancer after progression on the first line treatment. There is also another drug known as atezolizumab which is under clinical trials. Next update is on colorectal cancer. For 50% of the patient with metastatic colorectal cancer who have KRAS, NRAS or BRAF wild type tumors, cetuximab and panitumumab monoclonal antibodies to epithelial growth factor receptor in combination with chemotherapy can extend the median survival by 2 to 4 months compared with the chemotherapy alone. In 4 randomized clinical trials, intention to screen with 1 or 2 time flexible sigmoidoscopy versus no screening was associated with significant decrease in the colorectal cancer specific mortality. Next update is on renal cell carcinoma. For patient with von Hippel-Lindau disease and renal cell carcinoma, benzotrifan, it is a hypoxic inducible factor 2A inhibitor, leads to dramatic size reduction in both renal and non-renal neoplasm and offers a new treatment option. Pembrolizumab is FDA approved for adjuvant treatment after surgical resection of renal cell carcinoma in patient with high risk of disease recurrence. So that was it for the video, guys. I hope you liked the video, and I will be sharing this PDF on my WhatsApp channel. So make sure you join the channel to get this PDF, and also share this video with all your friends and do subscribe the channel. See you.